Hi, my name is Yvonne Chow, and today I'm here to talk to you about being a leader with imposter syndrome. It was the last day of the initial training of the first cohort of Leaders for Health Equity Fellowship. We had had a full 2 weeks of learning about the challenges towards achieving health equity. The data made it hard for me to believe I could or would do anything to even move the needle forward. Yet in spite of a system that didn't seem to work for me, I was sitting among some very accomplished fellows who were already doing some amazing work towards health equity, projects to reduce the inequities in this world. Fellows with PhDs and MDs after their name, sharing their powerful stories about why they were doing the work that they were doing and their subject matter expertise. One fellow was working to train the next generation of nurses from underrepresented areas. And another was working to empower health workers to advocate for their rights at the workplace. And here I was sitting, feeling uneasy. And I realized my imposter syndrome was acting up. You know that feeling, that tightness in your chest, that feeling of inadequacy, like a fraud who doesn't deserve to be in the room? The feeling that you only got to where you are because of luck or circumstance? When my imposter syndrome acts up, I really start feeling overwhelmed with emotions. And this time, it reached a new level, my identity crisis. And I, in front of 14 amazing individuals, had this ugly cry. You know that type of crying where there's snot coming out of your mouth, where there's so many tears coming down your face that you're trying to get so much breath into your air that none of the words that are coming out of your mouth are even making sense, that everyone is just sitting there like, oh, I want to comfort her, but I can't even understand what she's saying. That was how I was feeling. And it was easy for me to feel like I didn't belong because I'm not medically trained. I don't even have a master's in public health. My master's was in policy. Yet I was working in public health, advising on policies related to quality metrics and hospital operations that affected medical professions. It was easy for me to feel like I didn't belong because I jumped from job to job, not knowing what I wanted, not wanting to disappoint my parents. It was easy for me to feel like I didn't belong when my first professional job at a public health agency told me that I wouldn't get far without a doctorate next to my name. So to me, everyone with a PhD or MD after their name was more credible and had more authority than me. See, no one really told me how to deal with these feelings because I don't talk about emotions. I grew up with a suck it up attitude. And so what I did after the initial training was I continued chugging along. I swept it under a rug and I didn't address it. Over the past year, Leaders for Health Equity Fellowship has enabled me to learn more about my weaknesses and my strengths, to learn how to be clear about my asks of others, and how to turn the assets that I have into the power that I need to get the change that I wanted. One of my weaknesses was realizing I didn't know how to build real partnerships. I attended a lot of high-level meetings surrounded by people who said things like, let's collaborate together, let's help each other. And like magic, partnerships were created. They seemed to connect with one another. So I thought, that's how you speak as a leader. That's what you say. So when I started to try to set up these new partnerships, I regurgitated the same speech. I said, let's collaborate. Let's help each other. And lo and behold, nothing happened. All we did was have a great kumbaya moment where we each talked about how great our individual programs were, and we went back to our desks and back to our silos. And I started feeling frustrated because it made me feel like others were having these secret conversations and understood each other about what collaboration was. I felt like they had this amazing ability to read in between the lines and to see connections between programs that I just couldn't see. And so I felt like I wasn't getting something. And again, reinforcing the idea that I didn't belong. So it was through these failures that I realized I truly didn't have an idea of what I meant by collaboration. I didn't know how to operationalize it, but I was hoping someone else understood what I was saying and would act upon it for me. So to help turn this weakness into an asset, I had to learn how to be specific about what I wanted to really achieve. And I realized that the only way to collaborate effectively with the others was for me to connect the dots for them so that they could see the value that I could actually bring to the table. And that's how my collaboration with the Centers for Disease Control and Prevention started, with antibiotic stewardship programs among critical access hospitals took flight. I knew that implementing antibiotic stewardship programs in hospitals was going to be important for the future. And I wanted to make sure that my hospitals were prepared and were ahead of the curve in this work. Because better antibiotic use in a hospital means improved patient outcomes. When patients enter a hospital, their safety is imperative. And the data shows us that 30 to 50% of antibiotics that are treated or given are unnecessary and inappropriate. And every year, 500,000 people are infected by a hospital-associated infection called Clostridium difficile, and associated with 15,000 deaths a year. We also live in an age where more and more people infected by organisms are resistant to the recommended antibiotics. In the US alone, 2 million individuals are infected by organisms that cannot be treated by the recommended antibiotics. And of those, 20,000 die each year. The leadership training helped me think about collaboration in an action-oriented way. The first connection that I made was discovering that CDC had the same priority in terms of increasing the number of critical access hospitals that implemented antibiotic stewardship programs. From there, what I did was I listed out what I actually wanted from this collaboration with CDC. First, I listed what had happened between the two agencies previously. I listed out what I wanted from CDC, and I listed what I could actually offer CDC through this collaboration. What I wanted from CDC was a clear understanding of what support they currently provided to hospitals in this work. Because what I could offer CDC was our platform and our network, since we actively engage in all 1,300 critical access hospitals nationally. What I needed from CDC was data about how to monitor implementation of this program. Because what I could offer CDC was the creation of technical resources that are specific for critical access hospitals from our rural experts. Simultaneously, I learned how to get out of my little bubble of making decisions on my own and set up a communication strategy to understand if states and hospitals even wanted this work. And so we gathered together our stakeholders to get buy-in on this program. By being very specific and clear about what I meant by collaboration with CDC, I got results. And overall, I was able to make programmatic changes to my quality improvement program so that all 1,300 hospitals around the nation could receive support in implementing an antibiotic stewardship program over the next 4 years. And since then, I can gladly say that CDC and AFHE are collaborating together on an implementation guidance document specific to critical access hospitals. We had a CDC rep fly to DC for a 1-hour meeting just to talk to our stakeholders about the importance of antibiotic stewardship programs. CDC and AFHE has collaborated together to create awareness for the importance of proper antibiotic use through webinars and the sharing of data. And we continue to collaborate together in a meaningful way. But out of all of these accomplishments, the one that sticks out to me was when I was offered to be the representative for my agency on a federal advisory committee that gathers together experts from around the nation to provide advice and guidance to CDC and the United States Department of Health and Human Services in the areas of infection control, hospital-associated infections, and health policy, recommendations that the hospitals around the United States implemented. And when I showed up at that meeting in November, my imposter syndrome acted up again. And I was yet again confronted by the reality that I didn't have the right credentials to do my role justice. But the first thing that happened to me when I went into this conference room was the director who oversees this committee came up to me and gave me a hug saying, I am so glad you are here. When they told me that you, Yvonne, was coming, I was so excited because you are action-oriented. And that hit me, that someone outside of my office who had only met me once beforehand and only typically interacted with me over email saw me as action-oriented, who saw that I was wanted there and that I was at the table where I'd always dreamed of wanting to be. So I sat in my seat and I gathered up my courage and I reminded myself that I had something to offer them. And it's been an incredible journey and comforting to know that I am not the only one who feels this way. And it's been comforting being able to lean in to the discomfort and lean on like other like-minded individuals who are all leaders in our own right, working towards health equity. I still have the imposter syndrome lurking in the background, but I choose to be a leader in spite of my imposter syndrome, because I truly believe that we can turn the assets that we have into the power that we need to get the change that we want. Thank you.